Hello, my name is Eddie, and today I will be presenting a sacrum coccyx. We have a three-view sacrum coccyx. We have an AP axial sacrum, an AP axial coccyx, and a lateral sacrum coccyx, as due per protocol at our site, Current Radiology. The patient was a 67-year-old female. She was ambulatory. This is a geriatric case study due to the age of the patient. The physician's findings were not radiating at the time. And without further ado, let's get started. All of these images were taken on a Carestream Digital 14x17 image receptor. And to get these images, the patient was placed supine onto our examination table. We aligned our array to the mid-sagittal point, and this is our AP axial sacrum. Marker is marked. Our right side is marked laterally. This could have been collimated in to completely just focus it in on it, but patient was quite large and I did have some trouble finding my exact central ray, so I kind of left it open. They said it's okay, but we do have the entire sacrum visualized with a 15-degree cephalic angle. And to find this, we have to be 2 inches superior to the pubic symphysis. So 2 inches with a 15-degree angle would be here. So the entire base of the sacrum is visualized with the sacral foramina also being presented. We have both of our sacroiliac joints being presented. There's no obliquity, so one wouldn't appear larger than the other one. And we also do have L5, which is also a criteria from Bontrayer's diagnosis or his standards of care. Like I said, this could have been collimated in since we do have femoral heads, but we decided not to post-collimate crop it out due to the fact that, we can possibly find some incidental findings here, anywhere in position. Since patient did have, chief complaint was that she fell 2 days prior. So this shows decent density and KVP. I did have to technique this radiograph since everything, the AEC ion chambers were all disconnected, so this was all having to do with the manual technique. For this technique, I ended up using 85 at 25 or 24, 28 is somewhere around that. The digital Carestream, it likes to jump around from a lot to a little, and it doesn't allow precise increments. But it was 85 at 24, I believe. And this gave us good density, good contrast. We can see trabecular markings here. As you can see, camera just focused. We can see trabecular markings. We can see the outlines of the joint spaces. We can even differentiate little bits of, fluids. We could even see the endings of the psoas muscles. So because we can see so much detail, it has great contrast and enough density to make out some fine bony margins. As you can see, there was a fair amount of cloudiness there, and you can see little bubbles here and cloudiness here. We just go ahead and safe to say that that is all stool. Moving on. No immobilizations were needed for this imaging, and the patient was just supine. She wasn't shaking. She wasn't causing any distortion with a blur. This is our AP axial coccyx. Also, another fun, joyous fact, our tube angulation was completely broken, so I had to completely eyeball it. But it looked like 15, and then it did look like 10 degrees. So, everything came out just as we needed. So eyeballing it isn't the worst thing. Marker placed right side, lateral of the patient and lateral of the anatomy that we needed. We can see the coccyx here, and it looks like there may be a bit of angulation or obliquity here due to the fact that it's off the MSP. So it does look like it's leaning towards the right side. That could just be her anatomy or the way she was sitting, but it is a little hard to visualize since there is material here. But that is the coccyx. And that would be using a 10-degree caudal angle, and that would be centered 2 inches above the pubic symphysis, which wasn't a problem. We have good view of the anatomy without superimposition, so that's also a good thing. And from here, we would move on to our lateral projection. Now here's our left lateral sacrum coccyx. We have our left marker. The machine likes to burn out markers. but it was there. Had to do a little post-processing, but we made sure that it was on there. And from this one, we made sure that we went 3 to 4 inches below the crest of the crest, iliac crests. And we made sure to center about 1 inch posterior as well. So this would be about 1, 2, 3, 1 inch posterior. So we'd be penetrating roughly right here. Our AEC cell would be lined up right here, and I do believe that that one worked for this one. So I positioned the patient properly onto this AEC cell. That's why we have proper density, good contrast, trabecular markings are visible. We can see that if she was rotated slightly forward due to the hips not being completely aligned, but it's okay. It was enough to limit motion here, and we still have the entire coccyx and sacrum in profile, which is good positioning due to von Traeger, since we have S1 all the way down to the coccyx. Nothing superimposed here, and this would meet good criteria, and since we have enough density to see all our bony margins, good contrast, so we can visualize, stool findings here and bony margins. And we have sharp bony margins because I did tell patients to suspend their breath. So we have a crisp, clear images, so no repeats were necessary due to the technique or patient positioning. And that looks like it is all. I did shield the patient, but since we're due to the fact that we're all in the reproductive organs and it was hard to shield anywhere, I just shielded long bone just to try to save any kind of dose that I could. Collimation on this one was pretty good, or this one could have been a lot better on a repeat, but it wasn't enough to repeat it since we do have sacral foramina and all that. This one could have been tighter, but it's a very small target, and I doubt I could have even got my marker in there. So that was as good as I could do. But for future reference, I could probably do tighter collimation. This one, I made sure, I could definitely make tighter collimation, but they said just to leave it open. And I'm not going to argue with the technologist there, since if that's what they want, they can take it. And that's what that became. That's our sacrum, and that's our coccyx. I believe that is everything for tonight. Thank you.